So, dear friends and colleagues, let's start with the last of our webinars today, of our WHO webinars, also on the social media. You can follow them, and we record our webinars except the presentation of Melina. And we'll send you a link later on where you can have a look to the presentations if you are interested. I'm happy that we celebrate this very special World Hearing Day today, because today the World Report on Hearing has been launched. We talked about this before, this issue, and I recommend all those who haven't listened to the last presentation to download this report. It's really worth it. It's so new. It's better than each textbook for learning about hearing and ear and hearing care, prevention, identification, diagnostics, treatment, and so on. Yeah, the last session we have is one of our Deutsche Gesellschaft für Phoniatrie und Pedaudiologie, German Society of Phoniatrics and Pediatric Audiology. Also, its president is here, Peter Kummer, who already presented 2 webinars before. And this webinar will deal with hearing loss of people with intellectual disability, because we felt that there is much more knowledge necessary among professionals. And therefore we have an EFAS, a European Federation of Audiological Societies, working group on hearing problems for people with intellectual disabilities. And Melina Willems, it's my pleasure to announce her. She is lecturer at the Artevelde University of Applied Sciences in Ghent, and I know her for a long time because she is also a global director of the Special Olympics healthy hearing team. That means the hearing screenings which have been established during the Special Olympics, but she will talk by herself about this topic. Okay, Melina, the floor is yours. Okay. Do you see it? Okay. Good, this was our program for today. And now it's my pleasure to talk about implementation of a universal hearing screening for people with intellectual disabilities. What should be the logical consequence of what we found out all in Special Olympics, the necessity to care for the hearing capability of people with intellectual disability. So, intellectual disability is relevant to health policy and the society as a whole. The prevalence ID worldwide of intellectual disability is about 1 to 3%, as Melina mentioned. And it is slightly increasing due to the improved socio-economic conditions, intensive neonatal care, and reduced mortality that had led to an increased prevalence in the recent decades. Causes are genetic syndromes, other genetic reasons, cerebral lesions, for example, alcohol embryopathy, unknown causes in approximately 1/3 of the cases. The largest share of intellectual disability is among the population with Down syndrome, which make up about 15% of the people with intellectual disability. Going along with the extended concept of disease in the international classification of functioning of the WHO, we now are more aware than before for the body function. That means everything what has to do with the disability body function, social participation, self-esteem, independence of people with intellectual disability and their ability to act independently. So what Melina already mentioned, people with intellectual disability suffer from higher numbers of hearing loss than non-disabled people. The knowledge came by the Special Olympics, and my team and I, we belong to the first who published this in international journals. This was not known to many physicians at the time when we started in 2006. Something was published in 2003, but that was it. In 2008, we had a second publication and found about 24% of several thousand subjects who have been screened during the Special Olympics. This fits well with the number of 26% Melina mentioned. So we wanted to have a look at does this screening realistically reflect the hearing situation of adults with intellectual disability, or are there many false positives among them? And so we applied reference tests during the games and found a high specificity of 98% and a sensitivity of 100%. So obviously the screening is a very good reflector of what happens in reality. With my colleague Christiane Hai, and we checked later on in schools, special schools for children with intellectual disability and adolescents, whether that what we found out during the Special Olympics holds true also in schools, or whether we have there a completely different population, and it were the same numbers. The prevalence number exceed those of non-disabled persons of comparably age many times, as we have seen in Melina's presentation. But what many people do not know is that the hearing loss in people with ID can be prevented or effectively treated by regular ear checks and hearing tests. Therefore, we developed these guidelines. Ear canal cleanings, if necessary. It's completely different from what I told you during the presentation of the World Report of Hearing. The ear canals of people with intellectual disability have often different morphology, different anatomy, and different, and therefore the usual self-cleaning mechanisms are not that effective. People try to clean their ears by themselves. The earwax has a different composition, and so it really may establish a problem in people with ID. So it has been shown that early and consistent treatment of hearing disorders by means of hearing improving surgery, such as grommet inserts and tympanoplastic, is very effective. Hearing aids or hearing implants, cochlear or middle ear implants, implantable hearing aids can be applied in people with intellectual disability. Elderly people, if trained well, even after 70 years of age, are able to benefit from hearing aids. And continuous rehabilitation of hearing and speech skills are necessary. For example, for children with Down syndrome, often in the beginning they get some ear surgery, grommets. However, then you have the difficulty, cannot inspect the ear canal very well. You cannot recognize what is on. The grommets fall out and are reinserted several times. People have heart diseases and so on. And then most of the time, physicians give it up during the course of childhood or adolescence and forgot about it. So hearing tests from people with intellectual disability during the Special Olympics showed here of the 99 cases in which hearing loss was confirmed with diagnostic photon audiometry for the 2008 publication, 74% were unknown. Here you see that the white figures are the unknown cases of all cases we found, and 11 of them, of the 14 cases with profound hearing loss were unknown to date. So if people, and there is often a mix-up of hearing loss and the outer appearance of being intellectually disabled. Autism may look very similarly to profound hearing loss. Of course, those people are intellectually disabled, but they are much more hindered in their communication if they have an additional hearing loss. We had some small studies about follow-up after recommendations at Special Olympics. Everybody gets a letter with a recommendation where it is written, your hearing is okay, or you should consult an ENT or a hearing aid acoustician. However, when we followed up them, only 2 to 3% followed our recommendations to consult somebody, because people do not speak for themselves. They do not utter their problem. And there are too many people in between a medical doctor and a person with intellectual disability. I do not know, Melina, whether you have newer data about follow-up studies, but they were discouraging. What you see here are the numbers of several Special Olympics games, international, US, Indonesia, and they came out with all the same figures. About one quarter of them had a hearing loss or didn't pass the screening. So therefore, we recommend regular hearing screenings and tests of people with ID. But as we have seen in a little Europe-wide study, not much happens. There were recommendations and there were a program in the Netherlands, but it does not run any longer. And so we applied in Germany for my group for the checking whether universal screening of people with intellectual disability in their life environment makes sense. Before we did this, we wanted to check the technical solutions we have to go to people with intellectual disability, to schools, homes, sheltered workshops, and to test their hearing there. And we performed a study named Handheld, and tested all levels of ear and auditory pathway, outer, middle, inner ear, neural, central auditory functioning, including central auditory and speech processing. And we also wanted to check whether there is a correlation with the extent of intellectual disability. And here we tested 120 people, adults with intellectual disability, in a sheltered workshop. And the first surprise was when we measured the non-verbal intelligence of the people, the non-verbal IQ with a test, there was a continuum ranging from IQ of 55 to 92. So how come all those people into a sheltered workshop? Yeah, it might be that people who were drug dependent or alcoholics, also unemployed, find the way into homes and sheltered workshops and feel well there. So it has not to be that they are really intellectually disabled. 5 participants had hearing aids. Two other had 1 hearing aid. We had also control groups, but this is not important at the moment. What did we do? We did otoscopy, tympanometry, this is still from the Special Olympics. We did the pure tone audiometry as in the Special Olympics, and some initial training was necessary for the people, but then they performed quite well because no higher cognitive demands are put on the people, but only basal auditory processes are asked for. There is no great memory span needed, and it is too short for fatigue effects if it is done by trained professionals. However, more difficult than this air conduction pure tone audiometry was the bone conduction audiometry, because this confused people sometimes. We had another kind of pure tone audiometry, an adaptive self-test, which is applicable from 4 years on. And because we often use pediatric audiological methods for people with ID, we used it here. And so if people hear a sound, or if people press the belly of one of the animals which are related to some frequencies, they hear a sound, and if they hear the sound, they press the belly and the bear jumps, and if they don't hear, they press the sad bear. And in the end, they get an audiogram. Okay, another test checked frequency range with animal sounds, MFAST named. We also tried speech audiometry. There was some criticism about speech audiometry in people with intellectual disability, because this needs higher cognitive functions. And we tested it. We again took children tests, the Oldenburger Kindersatz test, which is uses an adaptive procedure and pseudo sentences of 3 words. Another speech audiometric test we used was the adaptive auditive speech test by Franz Konings, where you have 6 images on the computer screen and only 1 picture is named via headphones, and the person must identify which the corresponding image. We performed the speech audiometry in quiet and in noise. We also tried to perform on-site ASSR, auditory steady state response recording. And as another test of threshold, of objective threshold estimation, the growth functions of distortion products of otoacoustic emissions, which make an estimate and which extrapolate from some differing relationships between L1 and L2 of the two tones of the DPOE, the threshold, the hearing threshold. Then we also used a test of auditory processing, and here are results about the test performance, which was quite interesting for us. So here in the middle row, you always, or in the third line, you always see the people who performed the test well, and it were 116 for the DPOE growth functions and 4 dropouts only. Or ASSR with no sleeping persons but laying quietly, 113 performed it, 7 dropouts. A PTA, pure tone audiometry, 115 versus 5. Bone conduction was not that often necessary. Magic test, this was the test with the animal and where you press the belly. Also very well. Even speech audiometry was possible. Only 1 dropout in the RRST test in quiet. In noise, it was some more, it was 10. And Olkisa was more difficult with about 1/5 of dropouts. So what were the reasons for dropouts? No cooperation during the test, pure probe, headphone position, test was refused, restless participant, too difficult, motor help was required. So it was not always useless. Sometimes some help was required. Here we have the results, some examples of all methods performed in the patients. PTA bone conduction is violet, pink. Magic with the animals is red, and black is the PTA. So have at first a view on that. DPOE is yellow and ASSR is blue. So this is a participant with normal hearing. This is a person aged 33 years with a starting high frequency hearing loss. And you need to know that many people with intellectual disability have a faster aging hearing than others, in particular people with Down syndrome. So they start with age-related hearing loss at ages of 30. And so we recommended a recheck 2 years later. At the moment, there is no treatment necessary. Here below, you always see the results of the speech tests. Here we have a conductive hearing loss binaurally, bone conduction, air conduction, sensory neural hearing loss binaurally, mixed hearing loss on the who was treated inadequately with only a left-sided hearing aid, but needs it also for the right ear. And sometimes, but not very often, we had big discrepancies between the results. Okay, in these cases, more close diagnostic or more sophisticated diagnostics, maybe an ABR or ASSR measurement under general anesthesia is necessary. Okay, what were the results? Only 53% had normal hearing. It was a regular sheltered workshop. But in 10 persons, a recheck after 2 years had to be recommended due to the starting sensory neural hearing loss. 13% were borderline, retest was necessary, and 34% had a hearing loss. Only in 17% the hearing loss was known before and aided. So this repeats what Melina mentioned before. So at least 28% of the cases of hearing loss were unknown before. What were the most useful tests? We said our criterion was what gives the lowest thresholds. And the winner was MAGIC, which is a kind of, PTA. And also PTA was close. There was no, if you see the mean, the averaged over 4 frequencies, they gave mean thresholds of 25 decibel about, and were quite reliable. The speech audiometry was somewhat less good. However, if you want to fit hearing aids, you need speech audiometry as well. ASSR, this was not a good performance. Obviously, we would have to make more averages. DPOE was not that bad, but had sometimes sharp drops which we could not explain. Okay, so we have the MAGIC and the PTA. Speech audiometry is possible. DPOE, growth functions were partially suitable, and ABR, ASSR have to be improved in performance. Okay, knowing that, we applied for a program, for a study where we want to do this hearing screening in more than 1,000 people with intellectual disability of all ages, to test the feasibility and benefit the assessment of a program of low threshold identification. That means in their living environment, in homes, schools, kindergartens, and workshops, so that we come to the persons with intellectual disability and they do not have to come. We have also, we involve also a control group where we invite the families with a person with intellectual disability to come to the clinics for a screening, but we do not expect many visitors. So if we are successful with our program, this new form of healthcare has good chance to be implemented in Germany, because the project is funded with more than 1.7 million euro and is supported by the AOK, which is the biggest health insurance in Germany. So our results, which we expect, are that we have a relevant reduction of inadequately treated hearing loss compared to a spontaneous, to the strategy which is used today, where people come if somebody encounters a hearing loss. What we do if we find a hearing impairment, we do diagnostics at the same day or later day, also in the environment of the people, and we treat them if we can, also directly in the environment. We also do an economic cost-benefit assessment of such a program, and also want to have the age-dependent prevalence estimation in this population-based study. Here there are our partners, and Caroline Schaeffer is one of our partners. She will speak at next. Okay. This is what I told already. Here we have the places where we do the screenings and the numbers, what we do. It is not too difficult to find the people in the workshops. However, more and more people with intellectual disability are included in regular, in mainstream schools, or are integrated in factories with one single working place. And if we want to have the screening universally, we need to go to these places as well and find the people. Okay, we do this a similar screening then for the Special Olympics. Otoscopy, supported by a video otoscope, a screening autoacoustic emission measurement, tympanometry, and we do a screening audiometry either by PTA or by magic measurement, and we also do a complete pure tone audiometry as a reference test. If the screening is passed, it's fine. If not, the screening person does more of diagnostics, as you see here, or if necessary, a physician comes and travels to this place, physician who belongs to the project. And it is Philipp. You might have seen him before in the presentation, but Philipp supervises the screening persons by telemedical tools. For example, we can share the screen of the otoscopy, the video otoscopy, and he can have a look at that and can give recommendations, or he sees the outcome of the diagnostics and can give more recommendations. So if intervention is necessary, physician comes and replaces the earwax and prescribes medication or something to make a better ventilation of the ear, fits hearing aids, or sends people to clinic for ear surgery. Hearing rehabilitation will be done by the team of Caroline Schaeffer. So here can you see we do the video otoscopy and the screen is shared with the physician. Here's our handheld device with which we do all the tests. After 1 year, we will do a next examination and repeat the whole procedure. And we will see if we have found during the first screening that people wore already hearing aids or had some treatment, we check that and improve it if it is necessary, or send them to repair. And after 1 year, we will find, we will recheck to confirm the screening result of the previous year, to check the outcome after an intervention was initiated or recommended, or after we have optimized an already present treatment. We also want to identify newly occurring hearing loss and thus verify the usefulness of the recommendations of the IFAS working group's recommendation about an annual hearing screening. Maybe we do not need it every year, but every second year. We will find that out. We will carry out a new intervention if it is necessary. And we also have questionnaires where we assess accompanying diseases, that means comorbidities such as high blood pressure, diabetes, obesity, adiposity, and also the satisfaction with the hearing treatment and the hearing-related quality of life, which is very challenging. As Melina already mentioned, about 1/5 will not encounter any problems of the people we check. So, health economic evaluation, and this is my last slide. People with intellectual disability suffer increasingly from hearing loss, at least, or in increased number from hearing loss, at least 15% we assumed very conservatively of the total population, which are usually not known or inadequately treated. The implementation of a program of systematic hearing screening, diagnostics, therapy initiation, and long-term monitoring in the living environment of the people with intellectual disability might be useful. We hope that. We hope in a long way to improve the quality of life of those people and strengthen their communicative abilities, social participation, and independence. Thank you very much for your attention. Okay, this was a long journey now. Are there questions? Questions obviously in the chat. I will reply them if there are given to me. I can't see the chat. Here's the chat. Aha, okay. So, are there questions? Obviously not. Then I give the floor to our last presenter of the day today. This is Junior Professor Caroline Schaeffer from the University of Cologne. And she is, from her background, special. Are there questions? Is there a question coming? No. Pedagogue of people with hearing impairment, and you are not a teacher of a deaf, but special pedagogue and logopedist, right? Do I say it right?
That's okay. Right. Can you all see my screen? Everything's fine? Okay.
Yes, we can, and we can hear you. And
okay, great. Interested. So great. Thank you very much. I'm very happy to be here today and to share my experience with you. My name is Caroline Schaeffer. I work at the University of Cologne as an assistant professor in hearing loss and hearing rehabilitation in children and adults. In addition, I have worked for several years with children with physical and intellectual disabilities, where I learned a lot about augmentative and alternative communication. And today I'm going to talk about hearing rehabilitation in people with intellectual disability. So at first, let us be honest. What is it that we really know about hearing rehabilitation of people with ID? Well, we know something about hearing loss, about prevalence and outcomes. If you have a closer look at literature, there are even a lot of single case studies, but in my opinion, we don't really know a lot about rehabilitation concepts that fit all. We could even ask the question if there are concepts at all for people with ID. Let's have a look at the current state of research. We know that children with ID develop hearing skills and spoken language more slowly than children with hearing loss only. And furthermore, an open set speech understanding is often not achieved in that group, just as a competence in spoken language. But we have to admit the outcome is always very different, and it is not easy to make predictions, and maybe you should not make predictions at all. And there's more. We know that hearing care might be unsatisfactory, as we heard from Katrin and Melina. Hearing tests do not take place, devices are not checked regularly. One reason might be that parents express uncertainty about hearing and listening status, and this insecurity about success can lead to the invisible disability being pushed into the background and other problems taking center stage. Another observation that is often made is the reduced acceptance and wearing time of hearing aids and cochlear implants. This may further contribute to uncertainty about the hearing devices in general and their benefit. But in my opinion, what is really important is that parents describe the fitting of cochlear implants, for example, in most cases is helpful, also for children with autism spectrum disorders. So now let's talk about hearing rehabilitation. This is often, not exclusively, but mostly oriented to the learning steps according to URBA. However, if we simply transfer these to people with ID, problems could arise, as we should always keep cognitive development and cognitive status in mind as well. There is a danger that we will get stuck right at the first stage of detection and not make any progress at all after that. Yes, well, if people get stuck in hearing rehabilitation, this is often justified with the dual diagnosis of hearing loss and intellectual disability, but this might not be quite correct. Let's have a look at challenges that people with ID might face in hearing rehabilitation. On the left, I have listed some pre-verbal developmental steps like, for example, turn taking, joint attention, and object permanence that are normally acquired by children within the first year of life. And all of these steps are acquired incidentally and usually require little attention, but they have a lot to do with listening skills, as we will see. By the way, for people with ID, it is possible that developmental steps in these early stages play a lifelong role, which means even to adults. Let's look at an example. If you don't know, if you don't yet have the ability of joint attention and triangulation, then you do not know that you can communicate a sound event to other people. You then lack the knowledge that other people can have a different perspective on one and the same thing. What then can often be observed is the so-called hearing without showing. This is often described in people with autism spectrum disorder. Although they might perceive a sound event, they do not show any hearing response. And the only thing that can be observed are reflexes. And to trigger reflexes, you have to get pretty loud, believe me. Learning to listen does not work without social learning and feedback. And by feedback, I mean the feedback on both sides. On the one side of the person with ID and on the other side of the caregivers, assistants, parents, whatever. So let's take a look at the hearing development of Emil, 9-month-old. There we see it. And to explain, this is a video we are going to watch right now. To explain, Emil has a doll on his belly, and this doll can talk. The doll is turned on by the adult, and please have a look. How does Emil react? Can you hear it? So have you seen it? It's so powerful, the social smile. And we've also seen rudiments of turn-taking. Emil has started a conversation with the doll. So we have seen social smile as a listening response. So delightful. How do you think adults will respond to this? Right. They will give more input because Emil should smile again because he's so cute. And please be honest with yourself. Do you think all parents do the same with children with ID at that age? Probably not. And do you think that children with ID show such certain reactions that parents can interpret as smiles and joy? Probably not. And this reinforces a problem that later leads to delays in hearing development and problems in hearing rehabilitation, in addition to the intellectual disability, not because of it. And there's more to consider. Some people with ID may have additional physical disabilities and motor impairments that make it more difficult to access environment. Here, the understanding of cause and effect is usually acquired at a very early age. And if in addition, I can hardly verbalize my own playing actions, many important developmental steps are slowed down, all of which are also related to language development. In addition, other people might reduce the amount of language they offer, regardless of the hearing loss, but with the same effect, there's less experience gained. When we look at the goals of early communicative development, we can distinguish between communication mode, communication content, and communication function. And if I am honest, I think that in hearing rehabilitation, we are very much concerned about hearing skills, mode of communication, for instance, sign language, spoken language, or AAC, but this is always already advanced symbolic development. And if we look at the function of communication, then we see the meaning of it all. Why am I communicating? What does it mean to me? What can I tell others? And these communication functions are often a bit neglected, in my opinion. Well, you are probably wondering how this is supposed to work. I would like to show you an example I just found on the internet. You will find the link attached. The child you will see is probably not deaf or hard of hearing at all, but you could do it exactly the same or a bit different with a child with hearing loss. Just have a look.
Donald had a farm. And on that farm he had a dog. With woof woof here and a woof woof there. Here a woof, there a woof, everywhere a woof woof. Old MacDonald had a farm. And on that farm he had a duck. With a quack quack here and a quack quack there. Here a quack, there a quack, everywhere a quack quack. Old MacDonald had a farm. And on that farm he had a horse. A horse. You gotta tell me. With a neigh here and a neigh there. Here a neigh, there a neigh, everywhere a neigh, neigh. Old MacDonald had a horse. And on that farm he had a chicken. It's trying. With the cluck cluck here and a cluck cluck there. Here a cluck, there a cluck, everywhere a cluck cluck. Old MacDonald had a farm.
E-I-E-I-O.
And on that farm he had a cat.
E-I-E-I-O.
With the meow here.
E-I-E-I-O. E-I-E-I-O.
Remix.
Well, yes, what did you see? You didn't see a social smile, did you? But the lady just did fantastic. It was a turn-taking situation where the child was able to show his cause and effect understanding. And what is even more important, a wonderful listening situation in which a dialogue actually took place between the two. And have you seen how attentive the child was, how strong the eye contact? Everything is built on that, listening, communication, and speech. Okay, next slide, I'm sorry. I could tell you much more, show examples, make suggestions, but time is limited, so let's summarize. Especially for people with ID, the pre-verbal developmental status must be taken into account. And what is important, this can also apply to adults. And people with ID can only communicate auditory stimuli to others when they have acquired joint attention. And finally, that means that sounds and speech only make sense when hearing rehabilitation is a dialogue. And a common stumbling block is that the rehabilitation concepts that exist often assume that clients have already mastered all these skills. And as you could see in the video, however, the highest motivation for all development steps is to become active oneself. And we should consider this in hearing rehabilitation. Yeah, what I would like to say is that hearing is not an isolated, passive sensory skill that must be achieved first before one is being able or being allowed to communicate. So don't only focus on hearing as a passive skill, let people get active. And if you remain at the levels of attention and detection of sounds, you ignore communicative development. This is not an isolated competence. So don't make hearing rehabilitation to a hearing diagnostic all the time. Don't sit behind people in your hearing rehabilitation hours and make noises from time to time because people might find you strange, and they are right. Don't only observe reactions, that is diagnostics in rehabilitation, simply do rehabilitation. And if you want to see hearing reactions, make videos for observing. Start playing, start communicating, start using hearing as a communicative skill. Thank you very much for your attention, and thank you very much for having me here today.
Caroline, it's always fascinating what you show. And it's really new. Who knows that? Who knows that? And who follows that through? Yeah? I'm very proud to have you in the group, and I'm very keen in what we find out if we do this research now systematically with many people. And if we start maybe to try to rehabilitate elderly people with intellectual disability in hearing. Okay, are there other comments, questions from the audience, remarks? So many people still in the meeting. That's nice. Hello, Madalena. Nice to have you here.
Hello, sorry, I was unmuted.
Yeah.
Yes, it was very interesting, really very interesting, and thank you for all the presentations. I'm very proud to be in this FS group, really.
Okay, so then we conclude this day and go home, have meal, have dinner, and still celebrate a little bit the World Hearing Day. Have a good time. Bye-bye to everybody.
Bye-bye. Thank you.